This is a chance discovery cholecystectomy. Very small choledochal cysts to Dani type 1 in a 32-year-old young man. He had stones in the gallbladder. Now, the cholecystectomy, we were told just after he'd done it, so it was not a question to answer on the spot. And I wanted to submit to you the case. Should we operate on this case, or should we just simply watch him? 32.
This is your question.
Yeah. I have an idea what I would like to do, of course.
Pietro, what is the diameter of the dilatation?
There, it's 8 millimeters.
Now, I have first to do a remark. You said dilatation. Dilatation means that there is a mechanism that gives the dilatation. What you have to say is large. Large is neutral. Large does not mean a mechanism. So the first question is, your question must have been, is it a dilatation or it is only the white of the hepatic duct? For if it is only a large hepatic duct, there is no disease.
Yeah.
If there is dilatation, there is something that induces dilatation. Of course, the patient has a cholecystectomy. And due to the cholecystectomy, it is possible that there is something on the common bile duct that induces that. I cannot answer to the question.
I think this is a small initial Todani type 1 choledochal cyst. And that's my conviction. So on a small, generally we see them large, we see them, but this is a small discovered by chance. And in fact, the speculation about the pathophysiology of that is that there is pancreatic biliary reflux.
That's
It's free.
yeah.
I'm not moderating.
I think,
I was-
Hugo, you have a
And
question?
instead-
Yes, I was wondering, Pietro, in this case, do you have an anomaly of the pancreatico-biliary junction or not? Because I agree, first of all, I agree it may not be a type 1 cyst. And second, if it is, we know that the lifetime risk of developing cholangiocarcinoma is 3 to 5%. But is it the same in such a cyst like this? Probably not.
It is, for me, it is that. And there is no detectable anomaly of the pancreatico-biliary junction, but it is a physiological reflux. I mean, it is something that you can't see. If you go and measure in the bile duct where there is amylase, then you find amylase in the bile duct. But sometimes there is no underlying, visible, recognizable anatomical abnormality.
Daniel Cherki.
Je peux?
Yes, please.
So I have seen a few patients in my clinic coming for a large bile duct, so-called choledochal cyst. Number one, I looked at all the literature. There is no limit, there is no threshold for the size when you talk about large bile duct or choledochal cyst. And I think in your case, it's non-parallel. It's like an aneurysm. So maybe this is why it could be a cyst, which I'm not sure. Number two, this is during cholecystectomy. Who is doing the cholecystectomy? You or someone else?
Someone else.
No, because you can get bile from the gallbladder and send it to the lab to find if there's amylase in the gallbladder.
Too late.
Too late, okay. So number three, there's data showing that it's usually when you have a common duct between the choledochal duct and the pancreatic duct, which is over 1.1 centimeter or something like this. I don't remember exactly what it is. That brings the bile inside. And number three, it's usually not suspended like that. So at the end of the day, I think I would leave him alone.
Wouldn't you do an MRI or something else to? And the second question I would have: does the patient have an inflammatory bowel disease? Well, good. We have an MRI.
Yes, we did an MRI. Yes, and we could not find. Of course, I wanted something to substantiate my feeling, which is still suspended. Yeah, I wanted something to ground my feeling on that is still suspended.
Pietro.
And we could not find.
Joe has a question.
First of all, I do think this is a colodocal cyst. Morphologically, when you look at the Todoni part, for sure. And I think a few years ago, I presented a series of colodocal cysts, and I presented the part no one looks at, the Comey Classification. The Japanese elegantly delineated the biliopancreatic junction. And in fact, I don't remember what class this is, but it has to do with the angle of entry into the pancreatic duct. So this has all the features of a type 1 Todoni, and probably, I think, a Comey type 2. And what we forget, we see a lot of general surgeons that start operating on these, and some horrendous YouTube videos where they take staples and then they leave the whole distal part of the duct, where in fact, probably the cancer will eventually evolve. So it's very important to, maybe someone should reclassify Todoni with Comey, because those two classifications we kind of forget. And the Japanese have spent many papers and some beautiful diagrams. And yes, this is a type 1 and probably a Comey 2 distal.
Yeah, but Joe, he's 32-year-old now.
So what?
Okay? So what would you do now for this patient in that case?
Look, nobody knows the evolution of this until you say, well, they told me to leave it alone, I got cholangiocarcinoma. So if you think the patient's too young, you can counsel the patient, follow the patient, but when are you gonna, how and when are you gonna diagnose this? Wait till his CA19-9 raises, and now you've created another problem? I would be, personally, and you can disagree, I would be aggressive with this. Just my opinion.
The comment, Joe, is to say that he's 32. What would you do now if you
He's
think...
answered that. He would operate on this patient.
So you operate.
Yeah.
This is what I wanted to know. Any other...
So we have a risk of cancer. We're talking about what? You say 5%, probably as high as 10%. And as he gets older, the incidence higher. And I think it's playing with fire. And this is morphological for sure.
Professor BISMUTH?
There's a comment over there.
Yeah.
Would cholangioscopy help? Say spyglass, some follow-up of the cyst like that.
I think...
and what would be the indications eventually for asymptomatic cyst of that size?
I think with the spyglass, I would end up with my story of the princess that I will tell you last. But...
As I know Pietro, I know you, Pietro, I am sure you will give us some tricky thing.
Sorry, I didn't understand.
For instance, I think that I will propose... okay. I think that you will propose with the radiologist to put a small stent in the intrahepatic bile duct, which is possible transhepatically, and to measure the pancreatic liquid inside.
That will take me to my story of the princess, which I will tell you.
Ugo, a comment?
Coming to the comment of Joe, why do you think this has all the features of a type 1? Because it has no anomaly. It's a small bile duct dilatation above the cystic duct, a small one.
Because you're not going to see an isolated mid-segment bile duct dilatation routinely. And if this is a post-cholecystectomy dilatation, it's going to be uniform, number one. Number two, you see a neck. So
This is not a post-cholecystectomy dilatation. It's during cholecystectomy.
I understand that, but what I'm saying is, according to this, if you were to dismiss what I'm saying, you would not have these features of this, balloon going into the normal, almost normal bifurcation size, okay? And the other thing is, if you look, it balloons and then it dilates into the distal pancreatico-biliary duct, and this is a classic description of the Japanese, the Comey. Classic. And the size, again, I will say, is irrelevant. And 32 years old, I'm sorry he has a disease, but if he came to me, I would advise him to be aggressive.
Yes, but we have now, Pietro, we have just the cholangiography, so the dilatation, and we don't know if there is a common junction with the pancreatic duct.
In fact, we could not resolve an abnormality on the MRI.
Okay, so the MRI done 1 year later.
Surendra is.
No, I would like to ask
Yeah.
Joe, what do you propose practically?
I would propose a resection.
What kind of
Hepatico
resection?
digenostomy.
Please, speak loudly.
Give the microphone, please, because otherwise they cannot
I
follow.
think what Joe suggests.
Joe.
What Joe suggests is what I was taught to do, which is hepatico digenostomy.
Are you guys gunning
and
for me?
follow the bile duct into the pancreas. And
No, 1 minute. I ask Joe. Joe, what are you proposing?
I would resect it, including up to the bifurcation, okay, and then do a biliary anastomosis. But that's the easy part. The most difficult part is operating into the biliary junction in the pancreas. Because if you don't go to the pancreatic duct to remove these, then it's like doing nothing.
Exactly. So,
But Joe,
I had a video. In fact, I had a video 2 years ago of the same operation, and I showed how you can go into the pancreatic parenchyma and resect the whole distal pancreatico-biliary
in
duct.
fact, Joe, you don't go into the parenchyma because there is an embryological layer in which you can go into,
Correct.
follow
In
the bile
fact,
duct.
again, the Japanese,
very far,
but
almost nicking away.
almost completely exophytic. You're correct. Most of the time.
so now we have a patient 30 years old, asymptomatic, and you are proposing terrible surgery.
I'm a horrible man, but I think in terms of being able to follow this, okay, until you have a very good test to say, because size is irrelevant, what is the test that you use and to say, I've arrived at the time we should resect this. When he's 42, 52, 62, the age is irrelevant in my opinion.
Why don't you do a poll and see who would operate?
No, I will call later, but there are some
we have
interventions.
Sudendra who wants to make a
ask a
comment, I
question.
think. Sudendra, please.
Yeah, so one thing, of course, if we can document the abnormal junction between the biliary bile duct and the pancreatic duct, or the long channel, there are two things: either abnormal junction, where the bile duct is actually opening into the pancreatic duct almost at right angles, or there is a long channel. Now, one is that if the MRCP is not conclusive, then one of the ways, of course, the ERCP, which becomes invasive. Second thing is that there should be some retention of the bile in this. Okay, there will be delayed emptying of the bile duct, which is physiological, because the peristalsis in the bile duct will get affected. While the choledochal cyst is basically, when we are talking about, it's a dilatation. Okay, or what Professor BISMUTH is saying, it is the enlargement of the duct. Okay. So I will do a Hydra scan in this case to see that there is a delay in excretion of the radioactivity across the bile duct, showing their retention in it. Before I embark on this surgery for this patient, because it's a very localized, common hepatic duct area. Yes, it looks like a Todinta 1, but doesn't fit completely into it. Can there be something else which is responsible for that ectatic bile duct in that area?
Okay,
Yes,
Joe?
but-
One more comment. You know, when you say the accessory duct, which is described very well, you had a cholangiogram, okay, a regular cholangiogram. When you look at MRCP, and I went through this whole thing, and I started looking at MRCPs that didn't even have a colodocal cyst. The pancreatic biliary junction is, I would say, 50 to 60% of the time in my anecdotal observation, impossible to see on an MRCP. And I bring us back to the distal part because that's the part that gets left when people operate. And in terms of what he just said, it's irrelevant, bile stasis. So he has bile stasis. That's not a differential diagnosis of a colodocal cyst. From what we have now, it's morphology. Morphology, morphology, morphology.
What I said, before doing any kind of surgery in this patient, young and asymptomatic, you must be sure of the diagnosis. For you, you propose surgery, both of you, Joe and you propose surgery for the assumption of some reflux. Okay, I agree with you. If it is a form of cystic dilatation, a pathologic cystic dilatation due to the reflux and so on, I agree with you to do a prevention, but you must be sure about that. I was not joking. Why not to put a tube, really percutaneously, radiologists are very clever now, and then to measure if there is some pancreatic juice inside.
But until now, Pietro didn't propose surgery. Until now.
I mean, I'm thinking it so loud that people have... and the problem is that it may lead you, since I'm quite convinced on that, but I will tell you the story of the princess later.
This evening.
Okay. One thing for sure that I would agree with Joe, and when you discover, but if it is a real colodocal cyst in an adult, they all become malignant. Because we've reviewed all the series, they all become malignant, and I understand your worry about
No, it's not all. It's the risk is, in the literature, is quoted between 2 and 5%.
Yeah.
It's per year. So.
But I agree that's the only
5% per year.
worry about.
No, sorry, in general.
The one
per year.
series that you published at BISMUTH
I know.
was all cases that were really, you know, end of the line. People didn't know what they were doing. So you ended up collecting a large amount of patients with cholangio compared to the reported incidence.
Which is 4 to 5%.
Jean-Robert.
So any other
Jean-Robert
question?
was
Jean-Robert or Jean-Aimon, any
There's-
comment about
Rashad
that?
has a comment, I think. Rashad, you have a comment?
Yes, just a question. We're talking about the morphological abnormality, asymptomatic. Is there any biological or biochemical abnormality at all? Because if all is all right, I think an observation and as Professor BISMUTH follow up, and if any of the abnormality happens morphologically, it gets bigger, any biochemical or symptoms, then surgery will be justified. That's my opinion. That's how I would approach it.
So Pietro, everything was normal. Biology was normal.
Yeah, absolutely.
Okay.
Okay.
So let's poll it as
One last thing, you have a 32-year-old with a large IPMN. You're going to leave him alone? If it's a central duct, et cetera. We have a discussion when we talk about cancers or pre-cancer. This is pre-cancers, okay? The incidence probably about the same, but for some reason we get to these areas where we don't see a lot of them and we have trepidation. And when you compare it to other pre-cancerous lesions, we seem to have a different attitude. That's all. And it's just a comment.
Thought.
who would operate on this patient, just to give me, without further ado?
1, 2, 3.
4, that's all.
And who would
do
kind
as
who
but
would
now
follow
I
up?
think
kind of operation? Said,
Yeah.
okay, you are both to do surgery. What kind of surgery are you performing?
robotic hepatogenostomy following the bile duct into the pancreatic head and suturing it.
Removing the mucosa.
No, there's going down, down, down as far as possible in the pancreatic head without taking away the pancreatic duct, of course.
Very clever.
This is what I would try to do.
Very clever.
This is what I
You
would.
did it already?
Huh?
You did it? Yes.
Yes, and going into the with a small right angle dissector, you can feel where the pancreatic duct is. Into the pancreatic duct, palpating where the.
Jean-Robert?
Yeah.
Well, just about the technique, the resection of the whole biliary tract in the pancreas and the papilla, it's possible. It's possible to resect all the duct, all the main duct, all the main biliary tract. It's easy. I do many times this. But the question is not technical question. The question is it necessary to operate this patient, which will strictly asymptomatic and biological normal? That's the only question.
And what would
it's not
you,
a technical. It's not a technical question.
Jean-Robert, what would be your answer? What would you do? Would you operate on him? You
I
will
wait.
Okay, Pietro, you operated on him.
Not now.
Not now. Okay.
Not now. With Jean-Robert, Henri BISMUTH, and Surendra telling me, wait.
You will wait.
You will wait.
Okay.
I did not say wait.
Let me show you something.
I would puncture and measure the amylase. Yes.
Amylase first.
Let me show you something.
This is what I propose.